Buenos dias. Right, I'm just going to share my screen. Okay, all right, so I hope that you're able to see that now. Thank you very much for asking me to come and talk. I have a lot to get through, so forgive me if I go fairly fast, but I'm wanting to give you an overview of a number of areas. What I'd like to start with, though, is just a brief definition of telepractice or tele-rehabilitation. Telepractice is the term that we use in speech pathology, and that's in order to cover the work that we do with children as well as adults. The key to the definition is that there is a link between the clinician and the client, or somebody providing care to the client. So within this, a patient who is using health apps that don't have a link to a clinician would not be considered telepractice within our view of this. Also, just so that you understand what I'm talking about when I'm talking about telehealth, telepractice, tele-rehabilitation, this is how I think about all of these terms, with e-health or digital health being that bigger, broader health kind of system, and then drilling down to telepractice. So today I'm going to take you through a little bit of the research evidence for using tele-rehabilitation in speech language pathology, and I'm focusing on aphasia within the communication area, because I think that these are the people for whom providing therapy through this service delivery system is actually the hardest. And I'll also look at the evidence that we have for swallowing as well. I'm then going to take you through what it ends up being a fairly basic way of trying to assess the clinical need and matching it to the types of tech functionalities that you need in order to be able to provide a good service. And I'll very briefly touch on translation from research into practice, and how you might want to look at whether the tele-rehabilitation service that you've developed is performing the way that you planned. And I'd just like to acknowledge the work done by all of my colleagues in this area. So this is the bit I'm going to fly through. So in terms of aphasia assessment via tele-rehabilitation, we started this work in the early 2000s. We have been able to validate a number of formal tests over the years, including some high-level language tests. We're about to embark upon a piece of work to further validate the core outcome set for research measures in aphasia. This piece of work was actually put on hold because of the pandemic, but we're just about to begin this. So this is just to say that we have evidence and we know what we need to do in order to validly assess people with aphasia via tele. In terms of being able to treat them, there's a lot of small studies that have looked at one-on-one therapy via video conferencing, and that makes sense because we're translating what we normally do into this tele world. What I'd like to talk about very briefly today are two slightly different models of care, one being group therapy via tele, and the other being the Async work that I've done. So in terms of the group therapy, we had a PhD student who finished up in 2018. Dr. Rochelle Pitt, who developed Telegain. Now, this was a group aphasia therapy which was specifically designed for delivery via tele. So she did a feasibility trial, she tweaked it, she then looked at how effective that therapy actually was. The qualitative work that she did around that actually taught us a lot. So this used multi-point video conferencing. The patients were in their homes, or indeed one was travelling and so would call into local community halls and log in for the group therapy. The important thing about this piece of work is that in order to enable full participation by people with aphasia, we need to provide good communication supports. This is done by having resources and using technology that enables both the clinician and the patient to use them. So it's about being able to display images or videos using things like whiteboards, all of those types of tech features which allow the person with aphasia to actually participate fully. The qualitative work showed us that all of those wonderful benefits that you get from group therapy, you can still get them when you do group therapy via tele. It's harder work, but it's possible. And indeed, the speech pathologists felt that they were able to develop really good rapport. So that's the group therapy work. In terms of the async aphasia telework, there's been a number of other groups who have developed various systems, some of which connect back to the clinician, and that work has been done over the last 15 years or so. I've been developing a system which is very open, so it allows the clinician to design therapy tasks, and we're trying to expand that to be any type of therapy task. So you can import images, video, audio files, audio cues, video cues. The clinician designs those tasks, and indeed they build up a bank of tasks. They assign those to the patient does them on their device, the results are automatically sent back to the clinician, who's able to look at the data in terms of when tasks were done, how successfully they're done, and can modify them in a timely way so that the patient can continue to work. This system has also been adapted for voice therapy, and we are about to start on a trial where we've designed swallowing therapy. I just very briefly want to talk about another piece of work that we're currently doing, where we are translating an intensive comprehensive aphasia therapy, which involves all of these therapy types, which usually are delivered in person, and we're going to translate them into tele-delivery straight into the patient's home. Very briefly touching on the swallowing. So starting off with the Async system, Dr. Laurelie Wall, we used the eSalt to develop Swallow It, which enabled patients to do some very intensive swallowing therapy during their chemo radiation therapy for head and neck cancer. We did a 3-arm randomized control trial and looked at clinical outcomes as well as adherence and economic analysis. There's a series of papers that have come out which detail all of this work. Dr. Claire Burns again has, she set up a telepractice clinic for head and neck cancer. She started off with a pilot trial and then moved on to a randomized control trial using a hub and spoke model. Again, looking at service, economic analysis, workforce training, consumer engagement, as well as the clinical data as well. In terms of the economic analysis, we found a 12% cost saving, which was enough for this service to be seen as a sustainable service. And so this still exists now. Right, so now I want to get on to a little bit about things you might like to consider if you are going to embark upon a tele-rehabilitation service. So there's 3 areas that you need to consider, and they all interact. So of course, the patient factors. So the disorder type, confidence with technology, access to tech, motivation, all of these things are really important to think through. The clinician factors as well, professional practice requirements, their confidence with the technology, what sort of experience they have, access to training, and also a belief, whether or not they hold a belief that in-person services are always superior. Now, the pandemic has really broken that down because a lot of people haven't had a choice. They've had to move to this new service delivery. And what I would say is that tele-rehabilitation is different when to in-person services, and that clinicians do require adequate training. They do require time to practice the skills that they need in order to do this well. So in terms of the service factors, they need to think about training. They need to think about enabling clinicians time to develop that. So I've kind of touched a little bit on some of these ways to address these barriers. But one of the things that we're doing more and more when we are looking at putting tele-rehabilitation services into practice is this notion of co-design. So bringing both patients and clinicians and managers as well into that co-design of that actual service. So how do you begin to start? It's really as simple as the who, what, when, and where. Who's going to receive the service? Who's going to deliver it? What is the service? Is it one-on-one therapy, or is it group therapy? Is it counselling? When is the service being provided? Is it real time or not? And where? Is it being delivered to the patient's home? Is it being delivered to the ward? Is it being delivered to a nursing home? We quite simply put this into a table and just go through that process of thinking about the who, when, where. The what is a little bit different. You need to break that down a bit more into what is done, what is seen and heard, and by whom. So it's really about what is the task that needs to be directed and what does the client need to do. So this is an example, a very simple one. And this is probably something that people need to do when they're starting out. Once you've done this a couple of times, you probably don't need to go through this. At another level, there's this idea of actually breaking down that clinical task. So thinking about what the clinical interaction actually is. So this is the one that was done for TeleGain, which was that group therapy. So looking at what the activity actually is, thinking about what needs to be seen or heard, what the client response is, and only at that point do you then look at what technical functionality you need to actually enable that. So video conferencing, do you need the client to be able to draw on, to use a mouse to be able to draw something? Do you need them to be able to give you a verbal response? So after you've done that and you're ready to put your tele-rehabilitation service, put it into service, there's a number of different models that you could use to enable the implementation. This is just an example of some work that we did a couple of years back, where we took some work that had been done in Canada in dementia care, and we tried to adapt it for telehealth. It's a 7-step approach, and if you go to that link, you'll see how it's actually broken down. Now, this may or may not suit your setting, but there's lots of other models out there that might help. Of course, once you have your service, you want to ensure that it's delivering the service that you had actually planned. So you will need to look at the clinical outcomes that you're getting, the service outcomes as well, and that might be things around duration of sessions, number of referrals to other services. Consumer satisfaction is really important. And of course, the economics of it are vital. So now I just want to touch a little bit on some of the resources that have been put together. And as Julie said, a lot of this work has been gathered together in the last 3 months. So the CRE in aphasia recovery and rehabilitation, which is the group that I currently work for, put together a repository, and this began as a repository of resources about COVID. So there's lots of aphasia-friendly resources to do with hygiene, social distancing, etc. We also put together all of the tele-rehabilitation resources that we had, and links to all sorts of things, including which assessments have been validated and which haven't. So that's a great source for aphasia tele services. Queensland Health, which is the public health service in my state, and again, this is the work of Dr. Claire Burns. They had developed this wonderful training package which trains clinicians in how to assess swallowing via telehealth. My understanding is that this is available. So if you follow this link and register, I think it takes a day or 2 for you to then get access, but my understanding is that that is available. Speech Pathology Australia, which is our peak body, has really worked extremely hard. And again, this is the work of Claire Burns and Professor Liz Ward, who've really pulled all of this together. We have all of the telepractice resources there, including our position statement. And then in the Learning to Use Telepractice Learning Hub, there are videos. There's loads of videos in all sorts of areas of our service, showing people how to do telepractice. And then finally, just touching again on the Inform Me site, which Julie has actually talked through. So all of these various sites link up to each other. This site has the link to the CRE aphasia site and to the Q Health site. So it's wonderful that all of these groups have come together and they're sharing all of the resources that they have. Thank you very much.